Hi, good afternoon. It's John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn. We're pleased to have, once again, Dr. Larry Freeman back from the Department of Medicine to teach us about hepatitis, part 2 of his talk. Before we let him start talking, we want to go ahead and tease the upcoming Lunch and Learns. We have next week coming up kidney stones, modern evaluation and management. That's from our new Chief of Urology, Dr. Eisner. And then the following week, we have Dr. Ellie Tomczyk talking to us about lumps and bumps in the office. Again, that'll be next week. As a reminder, these are all up on our intranet, www.nwh.org/intranet, also known as Newton. And you can also find them on YouTube by searching Newton-Wellesley Medical Group. Jacqueline Kalelos has been very nice to us and has put direct links on the intranet. So if you're looking for one of the talks that you missed, that's a great place to start. Next slide, please. There we go. Just wanted to remind folks of the wellness programs that we've been running. I've been going over these on a weekly basis. I'll spend 3 seconds on them. The Physician Care Concierge, would I definitely encourage you to sign up for that, community.circles.com. Use the welcome code. It's a free service. They will tell you places to go, people to hire for things that you don't want to do. In fact, I just used it today because my freezer drawer is broken. It's not making ice. So I need to kind of get someone to fix the ice maker. And I'm certainly not going to be able to do that. So we'll be emailing them. It's a very nice little service. It's basically, it's covered for us. We have our weekly virtual meditation classes. We have our Peloton free membership, online coaching. I'm going to go quickly because I want to give Larry as much time as he needs, and the virtual yoga class. I've talked about all these. Anybody has any questions about any of these programs, always feel free to hit me up by email, by text. Next slide. All yours, Larry.
Okay, well, thank you, John. So I'm back for part 2 of viral hepatitis. It wasn't possible to cram it all into 30 minutes. These are my disclosures. So if you recall, I showed you this slide last time. It's the 5 principal hepatitis viruses. We discussed hepatitis A and B and mentioned hepatitis D, and today we will discuss hepatitis C and E. Just to give you the highlights of A, B, and D, the issue with hepatitis A, generally an acute self-limited disease with a very low mortality rate in people under 40, is that the incidence is increasing as a result of homelessness and drug use, starting in the West Coast and extending by the end of 2020 to about 33 states. So more cases appearing. The issue with hepatitis B is that you can't cure it because the virus enters the host hepatocyte and exists as a closed circular covalent piece of DNA and integrates into the host genome as well. It's not curable. So all we can do is suppress it. And we have several good drugs to suppress active viral replication, most notably entecavir and tenofovir, 2 types of tenofovir. Those are indicated in people with active viral replication. And for hepatitis D, the thing to remember is that it was once called the Delta agent, and Delta is ready when you are. You can't get D if you don't have B. So we'll turn to hepatitis C, and this has become a source of great pride to hepatologists. And it was the reason for the Nobel Prize in Physiology or Medicine in 2020. These are the 3 recipients of the Nobel Prize. Michael Houghton actually discovered the virus in 1989. He was an academic who went into industry, the Chiron Corporation, for 6 years and studied 1 million clones of the viral genome until he found one that bound to antibody in patient sera. He then tested this clone against pedigreed sera held by Harvey Alter, who runs the National Blood Bank. Alter was also involved, by the way, in the discovery of hepatitis B back in the 60s, but he didn't win the Nobel Prize for that one. And then Charlie Rice developed an animal model in which he implanted a human liver into a mouse and could study the biophysiology of the virus and the effect of antiviral agents on the virus. So these three collectively won the Nobel Prize. I'm very pleased to say I've been on programs with two of the three of them, but I'm sure they don't remember that. So hepatitis C, we now estimate affects 71 million people worldwide. In the United States, 3.5 million people, about a little over 1% of the population. And many of them, over 2/3, have active infection. That is, they have a detectable virus in their serum. We made great progress in reducing the number of new infections as a result of the discovery of the virus, testing for it, and the development of treatments, as well as an understanding of the epidemiology. But it's begun to rise again, and it's begun to rise in a slightly younger age group, ages 20 to 29, because of intravenous drug use. So it's still around, and you do occasionally see a case of acute hepatitis C. But most cases are chronic hepatitis C that was acquired years earlier. So injection drug use is by far the most common source of an infection. Back in the 70s and 80s, before the discovery of the virus, we called it non-A, non-B hepatitis. And it was prevalent in people who received blood transfusions. About 10 to 12% of transfusion recipients came down with non-A, non-B hepatitis. But in retrospect, transfusion-associated hepatitis only accounted for 4% of cases. Even back then, injection drug use was the principal mode of transmission. There is some sexual transmission if the levels of the viral genome are high in serum, as may occur in people who are HIV positive. And there is a risk of occupational exposure, but the concentration of the virus in serum is quite low. And so it's fairly hard to transmit, even if you stick yourself with an infected needle. So new screening guidelines came out in the past year, which now recommend that everyone 18 years of age and older undergo screening for hepatitis C, and all pregnant women should undergo hepatitis C screening during pregnancy. The only exception would be if the prevalence of hepatitis C in the population that you come from is less than 0.1%, and that's pretty unusual in the United States. So essentially, everyone should be screened now. Knowing about the virus and having effective treatments for it hasn't necessarily led to its eradication. We have a target date of 2030 to basically eliminate hepatitis C, but we haven't made a great deal of progress yet. 71 million people infected, but the diagnosis has only been made in around 15 million as of 2015. And treatment has been initiated in a very small number of people, although it almost invariably now results in cure. So we have a ways to go, and you should be screening all of your patients over 18 for hepatitis C by getting an antibody test at least once. Just a bit about clinical manifestations. There are extrahepatic features of hepatitis C, and it is a risk factor for certain other conditions, including insulin resistance and diabetes, as well as cardiovascular disease. It can cause, through immune complex deposition, membranoproliferative glomerulonephritis. It seems in some people to cause cognitive impairment. It may be a factor in rheumatoid arthritis. Probably the most visible effect is mixed cryoglobulinemia. It has been the principal cause of that disorder. It is a factor in certain B-cell lymphomas, and it may be a cause of porphyria cutanea tarda. So these are the diagnostic tests. Usually hepatitis C is diagnosed because a patient has elevated liver enzymes or an epidemiologic risk factor, such as past transfusion or intravenous drug use. But keep in mind that 40% of patients with chronic hepatitis C have normal liver enzymes, normal aminotransferase levels. So the screening test is an antibody to hepatitis C. It's a very good test now. And if it's positive, you get an HCV RNA level. And if that is detectable, if there is a level, then you characterize the virus a bit further with a genotype. Now, it used to be very important to do genotype testing because when we used interferon to treat hepatitis C, it worked better for some genotypes than others. Now we have two pan-genotypic regimens to treat hepatitis C, and they're over 95% effective regardless of genotype. So it's less important, but we do it anyway, in part out of habit and in part because if there is non-response, then we may need to know that. And finally, hepatitis C, unlike hepatitis B, does not cause liver cancer directly. It only increases the risk of liver cancer, hepatocellular carcinoma, or intrahepatic cholangiocarcinoma through the development of cirrhosis. So we really want to know how much scarring there is in the liver, and specifically, does the patient have what we call advanced fibrosis, stage 3 or 4 fibrosis, 4 being cirrhosis. So traditionally, that's done with a liver biopsy. And there was a period of time where everyone with hepatitis C underwent a liver biopsy. We now have non-invasive measures of liver fibrosis. They're not 100% perfect, but they can obviate the need for liver biopsy in many cases. This is the distribution of the genotypes in the United States. Notice that genotype 1, either 1A or 1B, is the predominant genotype. It turns out these were the hardest to treat with interferon-based therapy. They've become very easy to treat with what we call direct-acting antiviral agents. Genotype 2 and 3 were very much easier to treat with interferon. In fact, genotype 3 is now the hardest to treat with the newer agents, but we can still treat it very effectively. Genotype 4 is seen in Egypt, so I see an occasional patient from Egypt who has genotype 4 hepatitis C. Genotype 5 is seen in South Africa and other African countries, and genotype 6 in Southeast Asia. So mostly we see genotype 1 and an occasional 2 or 3. So this is what happens when you do a liver biopsy to stage. You grade the inflammation, you stage the fibrosis, so staging. And this is a Masson trichrome stain, which the blue shows the fibrosis, and it goes from stage 1 to stage 4, 1 being merely portal fibrosis, 2 being periportal, 3 being bridging between portal tracts or between central veins and portal tracts, and then 4 where there's actual cirrhosis. There are what's called regenerative nodules, the hallmark of cirrhosis. The problem with the liver biopsy, in addition to having to stick a needle in someone and possibly cause pain and bleeding, and rarely death, is sampling error. So you can put your needle in one place and see a lot of fibrosis. You estimate the area 65%, but if you put it in another place, and this is done essentially blindly, even if it's done under ultrasound guidance because you can't see these microscopic nodules, you can miss the fibrosis. Here, only 15%. So we're getting away from liver biopsy in many cases. We have these non-invasive blood tests, and there are a whole host of them. But the one that was designed specifically for hepatitis C is called FibroSure. It was developed in France and called FibroTest. And there are 5 parameters, as you see there. And they either go up or down, depending on the degree of fibrosis. And a formula is used. You don't have to calculate this. You just plug the numbers in an algorithm on the computer, and it gives you the stage. You can get a pretty good idea if the patient has cirrhosis or has very little fibrosis. There's an indeterminate group in between in which there's too much overlap and you can't really be sure. The next evolution of non-invasive fibrosis testing is elastography, measuring liver stiffness. And there are different types of elastography. Most commonly used is ultrasound elastography. And there's a portable machine called a FibroScan or transient elastography. It turns out it costs $140,000 and you have to pay $10,000 a year for maintenance, and the hospital will not pay for it for me. So I have to send my patients to ultrasound where they have adaptations to measure elastography, either acoustic radiation force impulse elastography or shear wave elastography, the various techniques that they use. The best technique is magnetic resonance elastography, but it's very expensive. So we don't use that unless we really need to know, and all of the other testing that we've done is inconclusive or inconsistent. So here's what the way the results are portrayed for any type of fibrosis testing. There's an elasticity score measured in kilopascals. It's really a measure of liver stiffness. And the lower the stiffness, the less the fibrosis. So if it's low, it's very unlikely to be advanced fibrosis. If it's high, it's likely to be cirrhosis. And in between, there's too much overlap. So here's what magnetic resonance elastography looks like in someone with cirrhosis, stage 4 fibrosis. If you look at the plain MRI image, you can't tell that patient has cirrhosis. It doesn't necessarily look like a cirrhotic liver. But if you do the elastography using magnetic resonance, you can see on the right panel that there's a lot of yellow and even some red. And that's a very stiff liver. It's over 4 or 5, the stiffness measurement. And that looks like a cirrhotic liver. So you have this algorithm where if the level is low, you can exclude cirrhosis. If the level of stiffness is high, over 5, and you're not surprised, then that's cirrhosis and you can assume it. In between, you may require a biopsy. But even then, you may follow this by serial elastography. Again, we don't do all these tests in everyone. I do the FibroSure test in everyone, and I use ultrasound elastography selectively, and only occasionally do we do magnetic resonance elastography. Right now, we have to send those patients to Mass General. Eventually, hopefully, we will have it here. It's just a modification of MR. So what happens when someone gets hepatitis C? Well, they're very likely to develop chronic infection. In contrast to B, where most adults clear the infection, in C, most adults develop chronic infection. And it's usually active infection, chronic hepatitis. And over a period of about 20 years, if you have chronic hepatitis C, you have about a 20% chance of progressing to cirrhosis. And the longer you follow people. And once you have cirrhosis, there's a risk of hepatocellular carcinoma up to 4% a year, and there's a risk of decompensation. Factors associated with cirrhosis, with fibrosis are shown here. The duration of infection, of course, is important. Cofactors like alcohol, more common in men, co-infection like HIV. So for patients with cirrhosis, you have to survey them for hepatocellular carcinoma, as we always do. And you can see how the frequency of hepatocellular carcinoma increases with time. So for hepatitis C, we survey people with cirrhosis, or more accurately, advanced fibrosis, stage 3 or 4, because if they have stage 3, they might have stage 4. For hepatitis B, it's not just the people with cirrhosis, but people with active infection. And depending on their ethnic group or sex, we start at different ages, as shown here. Regardless, generally, ultrasonography is used for surveillance with or without an alpha-fetoprotein every 6 months. Now, I came of age when alpha-fetoprotein was done in everyone. There's some data now to suggest that it's not that good. It's maybe only 50 to 60% sensitive, whereas ultrasound is 70% sensitive, maybe 80%. But most people still do both. So hepatitis C is curable. The goals of treatment are to cure the patient. The secondary effects are to reduce the progression to cirrhosis and all the complications that ensue. And this is the evolution of treatment, starting with simple alpha interferon back in the 1990s, given 3 times a week, to PEG interferon, which was given once a week for 24 or 48 weeks. Then the combination of interferon with ribavirin, and finally the direct-acting antiviral agents, which are much more effective and completely non-toxic, whereas interferon and ribavirin are associated with a lot of toxicity. So I had the privilege of being on the FDA Antiviral Advisory Committee. You've heard about FDA advisory committees lately. I was on that one for many years and was involved in the approval of many of these drugs. The direct-acting antiviral agents are so effective and so non-toxic that they stopped asking for our advice after a while. And so there have been no meetings for years, for at least the past 4 or 5 years. So I quit the committee because they require you to fill out so many conflict of interest forms every year that it was actually burdensome with no return on investment. So here are the agents that we use, and they derive from products of the hepatitis C genome. There are structural proteins, capsid and envelope proteins, and then there are non-structural proteins or enzymes. And that's where the antivirals are directed to their products. So either a protease, something called NS5A, and then polymerase. And there's a list of all of the approved agents in the United States by category. They're all in various combinations quite effective, but 2 are pan-genotypic. Now, most of them have high antiviral potency. Examples are shown here. Sofosbuvir is used often because it also has a high barrier to resistance, so genetic mutations don't develop. So that's been a backbone of regimens for a while. But these are the regimens that we use most commonly in practice, and the 2 that are highlighted are the 2 that are pan-genotypic. And I've been able to reduce my choice of regimens now to those 2 in almost all cases. Some of it depends on what the insurance company will approve. But sofosbuvir and velpatasvir, also called Epclusa, and glecaprevir and pibrentasvir, also called Marivet. You've seen advertisements for them. They're pan-genotypic, and they can be used in some patients who have been treated and didn't respond. Then there's a backup regimen, sofosbuvir, velpatasvir, and voxilaprevir, which is also called Vosevi, which you can use for all genotypes in people who have taken one of the other regimens and either relapsed or didn't respond. And those are few and far between. I've only used that regimen once or twice. You treat for a limited amount of time in each case, either 12 weeks or for glecaprevir and pibrentasvir 8 weeks, and the cure rate is remarkably high. And you don't have to remember all this. There's a website, hcvguidelines.org. It's sponsored by the Liver Society and the Infectious Disease Society. And it's very easy to navigate. You determine if your patient is treatment naive, never having been treated before, or treatment experienced. Then you look down for either whether they have cirrhosis or not. You get a pan-genotypic regimen, or you can pick out the genotype and then indicate whether they have cirrhosis or not. And you'll get a choice and selection of backup regimens. So that's all I have to say about hepatitis C. It's been a very exciting story. It's become easy to treat now. And because we've done so well with it, non-alcoholic fatty liver disease has begun to dominate hepatology practices and has displaced hepatitis C as the most common disease that we see. Now, I'm just going to spend 2 minutes on hepatitis E virus. I actually did a CPC in the New England Journal a few years ago, in which this was the diagnosis. It was the first case seen at Mass General. I actually got it right, and I knew I would get it right because I ran the case past Harry Schrager, and he told me I was right. So hepatitis E virus is very interesting. It is the most common cause of acute viral hepatitis in the world, although we almost never see acute hepatitis E in the United States. It's common in the Indian subcontinent. It's also seen in Middle East, North Africa, and there have been outbreaks in Mexico. It's an enterically transmitted virus, and it was discovered as a result of large waterborne outbreaks in India. Has a mean incubation period a little longer than that of hepatitis A. And for reasons that are not entirely understood, it has a very high mortality rate in pregnant women. In the United States, you may see it in an occasional traveler, but interestingly, if you test everyone, about 16% of the population has antibody to hepatitis E virus, and they haven't traveled outside the country and they never had an illness that sounds like hepatitis, so we don't know what that's about. The disease may be mistaken for drug-induced liver injury. In Europe, particularly, there are genotypes 3 and 4 that seem to be spread by meat, by swine in particular, either through a pet at home or consumption of undercooked organ meats. Again, we haven't seen that much in this country. So in India, hepatitis E is the most common cause of acute liver failure, and all the top causes are due to viral hepatitis. In the United States, acetaminophen is the most common cause, and drug-induced liver injury is second. Viral hepatitis accounts for only about 10% of cases. So they have a different epidemiology, and they see a lot of it. Generally, it's a self-limited disease, but there are cases of chronic hepatitis in immunosuppressed persons. And it has a whole lot of extrahepatic manifestations, most of which appeared in the New England Journal CPC discussion that I did. These are some of them, and then there are other complications that can be seen. So it's an interesting disease. There may be some benefit to ribavirin in patients with very severe infection. There are a couple of vaccines that have been developed in China, one of which has been licensed. We haven't had a need for that here. It'll probably decrease in frequency if public hygiene improves. But right now, they have bigger problems with COVID. So we'll have to see how that affects hepatitis E. So thank you very much for your attention. I'd be happy to answer questions in the 20 seconds that remain.
Thanks, Larry. I was challenging people to name some rock stars they know who've had Hep C, but I'm the only one answering the question, so that's okay. One question I did have about Hep C was a lot of times we'll find patients who accidentally didn't know they had it, as you mentioned, and cleared it on their own. You know, I think Keith Richards does claim his super immune system did clear it on its own. He didn't need any treatment. Do you, as a primary care doc, would you consider repeating viral loads, or do you think the test is sensitive enough that one negative is good?
I think generally one negative is good. It depends on lifestyle. So if the patient is an active intravenous drug user, then you probably should be checking for hepatitis C from time to time. If they're clean and sober, and they have an antibody, and HCV RNA is negative, I think that's fine.
One and done, and that's it. Okay.
Yeah.
All right. And what percentage of those patients would you say cleared on their own? Would you say?
Oh, up to about 20–25% may. They do. There are certain indicators. There's something called IL-28B, interleukin IL-28B, or lambda-3, a marker that's associated with clearance of the virus, as well as responsiveness to interferon, the particular genotype CC. So there are some people who clear it. I had one patient who I started interferon therapy on. After 2 weeks, he quit it, and because he couldn't stand the side effects, and he was cured. So there are some people who clear it more readily. Again, none of that matters too much now with the direct-acting antivirals.
Right. I mean, I remember trying to get people to stay on that 48-week treatment. It was impossible. So I guess that's...
Yeah, I've taken care of some of these rock stars with hepatitis C. I can't tell you who they are. Or I've had friends who've done that, but they're out there. There are a lot of them out there.
Oh, yeah. Thank you so much. Once again, tune in next week. We'll have Dr. Eisner talking about stones. Larry, appreciate your time as always. Don't forget, every Wednesday morning, you can hear Grand Rounds. Always a great topic. I think next week we have PMR. That's Wednesday mornings at 8:30. That comes directly to your email box. Please let Tammy or Dr. Friedman or even myself know if you're not getting those emails. Thanks again, everyone. Have a great weekend. Bye.
You all.